Greetings, students. This PowerPoint is on periodontal therapy overview. The reason for this overview is to try to bring everything together. You have not yet learned all of the material that is presented in this PowerPoint. However, there is a lot of redundant information, and so you may skip the slides that you already know, but I want you to pay attention to areas where you may not know so that you can continue to bring everything together as far as a periodontal therapy diagnosis, prognosis, and treatment plan, and basically overview of the patient's response and so forth. Dr. Campos actually contributed to this PowerPoint, which is why I also listed her name. Thank you. We will follow the outline listed below in terms of describing an overview for periodontal therapy. We will discuss non-surgical therapy, the goals of non-surgical therapy, procedures that are contained within non-surgical therapy, the treatment plan, outcomes, and then finally we will touch upon surgical therapy, which will be covered in the winter of your DS2 year. Periodontics is defined by the American Academy of Periodontology as follows. It is the specialty of dentistry that encompasses prevention, diagnosis, and treatment of diseases of the supporting and surrounding tissues of teeth and dental implants. Basically, it is the foundation of which everything is built. Before beginning treatment, we must always provide a comprehensive exam as well as a periodontal assessment. As far as non-surgical therapy, there are various non-surgical steps which can be utilized to eliminate inflammation and disease. This non-surgical therapy or phase is also known as initial therapy, the hygienic phase, phase 1 treatment, or anti-infective phase. Although most non-surgical plans are relatively similar, there can be a variation depending on the factors that the patient presents with as far as systemic and or local. Therefore, each patient presents with unique findings, and because of that, we have to make plans that are custom made for each patient. So remember, it is a case by case basis, but for the most part, the non-surgical plans should be similar, but they may vary. Now let's begin with our periodontal evaluation to go through the questions and factors that we need to in order to be able to collect the data that we need to make a diagnosis as well as a prognosis, and then take that information to develop a treatment plan. So first and foremost, we have to review the medical as well as the dental history. We need to know, do we need any medical consults? Does the patient has any systemic concerns that need to be addressed that we may need more information on? Will these systemic factors have an impact on the periodontium? Second, we need to know what the chief complaint is, because the patient is coming to us to fix a problem. Not only do we have to educate them, but we also have to satisfy their chief complaint if we expect them to come back in to be a patient. Sometimes getting to their chief complaint, we have to give them further knowledge to understand if their chief complaint can be addressed or not. And if it cannot, we have to be able to provide a basis for why it cannot. Next, the risk factors. We want to look at, again, we've discussed systemic briefly. We also want to look at local contributing factors, or are there factors that for some reason or another they can't get into the dentist, so there's a problem with compliance or what have you. We have to look at all of those risk factors. Some of those factors are going to be internal and some of those factors are going to be external. We need to look at the signs of inflammation, ensure that we have current radiographs displaying their current status, whether that be health or disease, and to evaluate for microbiological, genetic, biochemical analysis if indicated. In doing our periodontal evaluation, we start with the extra as well as the intraoral exam. In completing an extraoral exam, we are palpating the muscles of mastication, ensuring that there is no problems as far as TMD, temporomandibular joint disorder. Intraorally, we are looking for any lesions that are abnormal, anything that may contribute to the destruction of the periodontium, that may give us some information that there may be something systemic going on. We also have to evaluate the gingival characteristics. In doing so, we actually utilize the periodontal probe, and with that, we are looking at the probing depths, we are checking the attachment levels, assessing whether bleeding on probing is present, the width of the keratinized tissue, whether there is furcation involvement, as well as other dental issues such as periapical radiolucencies. We also assess the presence of dental plaque and or calculus, and we want to ask the patient about the frequency at which they brush, floss, as well as the history. Have they ever had scaling and root planing? Have they ever had periodontal surgery? All of those things will help us to evaluate where the patient is now. In completing a periodontal evaluation, we not only look at the periodontium, we also look at the teeth. We look at the caries assessment based on how many lesions, carious lesions, a patient has present in the mouth. We also look at the risk factor for them developing new decay. What is their diet like? How often are they introducing sugars into their mouth? What is the time frame for that? We look at the status of the restorations. Are the restorations intact? Is the marginal integrity of the restoration fine? Are there overhangs on that restoration? The contour of that restoration. We also look at the prosthetic appliances. As far as the prosthesis, is the prosthesis ill-fitting? Is it torquing a tooth, causing that tooth to be mobile? Then we look at the occlusal examination. In an occlusal examination, we're checking for mobility and fremitus. We're also looking to see if there's any occlusal interferences that may require adjustment. Next, we look at determination and assessment of risk factors, those being either systemic or local, things such as diabetes, smoking, or other conditions. Once you have collected or completed your periodontal evaluation, you may now start to fill in this form that you see now, which comes directly from Axiom. And if you were in the clinic, you would actually record your findings as you went along in your examination. So this first tab is the periodontal findings, and your second tab will be your diagnosis, prognosis, and treatment planning tab, which you take your critical thinking skills as well as the information you or the data that you have collected, and you determine what your after you have taken your clinical findings, your diagnosis, and your prognosis, the next step would be logically to create a treatment plan that addresses the signs and the symptoms of the disease. In addressing the signs and the symptoms of the disease, the goal would be to actually eliminate those signs and symptoms of periodontal disease. In reviewing the goals overall for periotherapy, the ultimate goal is to achieve health, comfort, aesthetics, and functions. That can be done both around a dental implant as well as the natural dentition. Overall, in achieving a healthy periodontium, you want to ensure that you have the absence of inflammation, redness, swelling, suppuration, and lack of BOP, bleeding on probing. Now we want to look a little bit more closely at the goals of non-surgical therapy as far as controlling, eliminating, or minimizing: 1, the primary etiologic factors; 2, the local risk factors; and 3, the systemic risk factors. When we do all of these things and we're successful, then we should be able to stabilize the attachment level. This means that we have now stabilized the periodontium and you no longer have apical migration of the junctional epithelium. In looking at the primary etiologic factors such as microbial plaque or what we call a biofilm, they are necessary. The bacteria are necessary, or the biofilm is necessary in order to cause the disease, as it is the primary etiologic factor. Anything that is added onto the microbial plaque or biofilm would be a secondary systemic or local contributing factor, meaning it does not cause it, but it just contributes to the disease. You also need to have a susceptible host. If you don't have a susceptible host, then it does not matter how much biofilm or bacteria you have, you will never develop that disease. So we all have to remember that a genetic component plays a part. So how do we control the primary etiologic factors? Well, the way you control it is through patient training, education, and reinforcement of the proper home care. You want to make sure the patient is adequately debriding the biofilm or the microbial plaque. How do they do that? They need to brush, floss. Sometimes they need to use interdental aids. And when they come into the dentist, things that we can use to help reinforce the behavior would be plaque index and then positive reinforcement. The plaque index, remember, is for the patient. It is something that we use, disclosing solution, to show the patient the areas they are missing, because sometimes our patients can't see the plaque. And so it is important for you to be able to help them to visualize the plaque and then to be able to remove it. Also, maintenance plays a major part in being able to control the primary etiologic factors. Bacteria or the biofilm have to develop and become pathogenic over time. So if we remove the biofilm often, such as every 3 months, then the bacteria or the biofilm has less time to mature. And if it doesn't have time to mature, then it doesn't become pathogenic. So frequency is very important. And finally, the removal of the plaque and calculus, which happens on a daily basis with the patient and on a 3 to 4 month professionally when the patients come into the dental office. In controlling the primary etiologic factors, one of the ways that is accomplished is by scaling. Scaling is actually the instrumentation of the crown and the root of the teeth to remove plaque, calculus, and stains from these surfaces. Notice that I did not say root planing. Again, just remember that scaling is to remove plaque, calculus, and stains from the teeth surfaces. The next way to control the primary etiologic factor is to complete root planing. Root planing, which is different from scaling, is a treatment procedure that is designed to remove disease cementum or surface dentin that is rough, impregnated with calculus, or contaminated with toxins or microorganisms. Now we have the local contributing risk factors. Remember, again, they do not cause, but they will help exacerbate the disease. Local factors may increase the biofilm retention. They may increase pathogenicity of the biofilm, or they may cause direct damage to the periodontium. I will provide an example of each one of these to you. In viewing local risk factors and biofilm retention, one of the major risks or local factors that we see are overhangs as a result of restorations that are improperly contoured. We also see grooves, calculus, or any other factor that may have an impact on retention of the biofilm or of microbial plaque. If you look at tooth number 30 as well as 31, they both have large overhangs. These overhangs would cause plaque retention right apical to them, and the patient would not be able to adequately remove the plaque from underneath the overhang. This results in an inflammatory reaction because the plaque is allowed to stay on the tooth. It becomes more mature, which means that it becomes more pathogenic, and resulting overall in this radiolucent bone where you have loss of mineralization and ultimately bone loss. In viewing local factors and biofilm pathogenicity, we have to look at what type of things would actually retain microbial plaque or the biofilm. Well, calculus is one of the major substances that retains plaque and enables the maturity of the plaque. If you look at this smiley face, which is symbolic of calculus only because of its porous and spongy nature, well, more so because of the porous nature, that means that any of the biofilm or microbial plaque can basically embed themselves in any of these openings. And once they get in any of these openings, even if you're flossing and or brushing, it is highly unlikely that you'll be able to remove any of that microbial plaque. The other thing is this is usually found subgingival. So again, unless we debrided the area, we would not be able to remove this. The plaque would be able to be retained inside of the calculus and it would be able to mature. I also put in a couple of other slides just so you could see other factors or other local contributing factors. When you look here, at the canine, there is a groove, and again, grooves are retentive. There's also a vertical defect, basically where the arrow is pointing just short of on the left slide. And anytime you have a vertical defect, just remember that non-surgical scaling and root planing will not take care of that defect. It will not resolve the defect. Therefore, if you're going to resolve it, you would actually be looking to refer to the periodontist so that they could do a surgical procedure to get rid of that defect. Another local contributing factor would be hopeless teeth that have gross decay. Any areas of decay are going to also retain plaque and or calculus. So you have to be very careful to try to get rid of these teeth as part of phase 1. You want to remove anything that is a reservoir for plaque and or calculus, especially if it is not going to be useful to you in your treatment plan. In the upper slide, there is no way for us to save that molar. Therefore, tooth number 19 actually needs to be extracted, and it will, by removing it, we are removing again a source of plaque. Just as a side note, if you look at your radiograph that is to your right, that has the crown and the root canal, and we can see on the mesiobuccal root that there is definitely something going on with that root. We want to go ahead and either get an endodontic consultation or make a decision about whether or not that tooth can be retained. In your phase 1 treatment plan, you want to decide which teeth are salvageable and which ones are not, and you want to assign your prognosis to those teeth. That in itself would have a questionable prognosis, and once you find out if there is further infection going around that mesiobuccal root, that may actually decrease the prognosis even more, deeming the tooth non-restorable. At this point, because we don't have any further information, we don't know, and we would assign a questionable prognosis to that tooth number 30. Okay, now that we've talked about the local contributing risk factors, I'm going to briefly talk about systemic risk factors. I know you guys have had this before. However, we're trying to relate it to treatment planning now. So the smoking, remember, is the #1 modifiable risk factor. And also remember that you have a decreased likelihood of improved prognosis by 60%. So what does that mean? That means even after you've done your non-surgical therapy, your scaling and root planing, that you only have a 40% chance of improving the prognosis of a smoker, especially a heavy smoker. And just remember, anytime you have systemic diseases that are uncontrolled, that have an impact on the periodontium, that your results will also not be as good as they would be as if you had somebody that was a controlled diabetic or somebody that was periodontally healthy and systemically healthy. When performing non-surgical procedures, There are several procedures that can be done. First and foremost, we always do oral hygiene instruction, and then we verify that the patient has learned the behavior. Whenever you are demonstrating to a patient how to floss or brush, you always want to watch them first and ask them if you can modify what they're already doing. You never want to tell them that you're teaching them to brush, because that's assuming they've been doing it wrong this entire time, when in fact you just want to make them more effective at debriding their teeth or removing the plaque. Next, instrumentation with hand instruments and or the ultrasonic. Research has shown that the two methods are both effective. However, in my hands, ultrasonic may be more effective, whereas in your hands, the hand instruments may be more effective, or a combination thereof. Therefore, each patient, you may find a different combination works for you. But again, the research shows that they equally remove the plaque and or biofilm, as well as calculus. Finally, correcting contributing factors, both systemic and local. This may involve the use of a medical consultation as well as other healthcare and or non-healthcare professionals. Non-surgical therapy also entails host modulation. Host modulation is a technique where we use medications to modify the host response to a stimulating agent such as bacteria. When we utilize this technique with periodontitis, we are basically stopping the host or the patient from over responding to the plaque, because we know that when the patient responds to the plaque, then the cells in our body actually cause breakdown of the collagen that is a part of the periodontium. The purpose of this host modulation is to reduce tissue destruction and stabilize the periodontium by minimizing the response of the host to the stimulating agent. An example of this would be Periostat, which is doxycycline, 20 milligrams twice a day. It is a part of the tetracycline family. Tetracycline, as we know, is an antibiotic. However, because the doxycycline is used in such a low dose, it is not considered an antibiotic because it is beneath the therapeutic value of becoming of being used as an antibiotic. What actually happens is the periostat actually reduces the collagenase activity in the gingival crevicular fluid. In reducing this collagenase activity, it reduces the breakdown of collagen, which is contained in the gingival tissue as well as in the bone. It is important to utilize things like this because sometimes the host cannot respond adequately or is over responsive, and therefore you have to make adjustments by using medications such as the periostat in order to inhibit the destruction that can come along if it was undisturbed, if the host response was undisturbed. This slide is being included just for completion's sake. In other words, we know that anti-inflammatory as well as pro-inflammatory mediators have an impact on the inflammatory response. However, what you just need to know is that we sometimes use anti-inflammatory agents to help treat periodontal disease. One of those would be NSAIDs, non-steroidal anti-inflammatory drugs, such as ibuprofen. Although we don't use those long term, they have been used in the treatment of periodontal disease. Okay, now we're ready to talk about treatment plans. In a treatment plan where you have diagnosed gingivitis, then you want to start with the following. A 1330, which is patient education and oral hygiene instruction. Now you do this as often as you need to with the patient. If a patient comes in and they have poor plaque control, you would do a 1330. If you've seen them before and you've done it the last time they were here and now they're here 6 months later, you would still do it as many times as the patient needed. Remember, we have to continue to do reinforcement if we want to have a behavioral change. The next thing would be an 1110, which is an adult prophy, where you would do scaling, which is the removal of calculus, plaque, and stain removal. This can be done either with your hand instruments or with the ultrasonic. Next, you would do a fluoride only if they had a moderate to high caries risk. Remember, if someone has a low caries risk, they don't really require fluoride. However, if you're still going to ask the patient about having fluoride, then you want to let them know that you are offering it from a preventive standpoint because they have some recession somewhere or because of just pure prevention. But you always want to give the correct rationale, and just to offer everyone fluoride when it's not needed is not, it should not be a part of your treatment plan. Next, we have the frequency at which you're going to do the adult prophy. So that prophy is normally done every 6 months. However, let's say a patient has braces or something else is going on where they have limited dexterity. You may increase the frequency to 2, 3, or 4 months, whatever is indicated for that particular patient. And it may be just for a set time. So for instance, if someone has poor plaque control and they're in braces, you may do that every 2, 3, or 4 months for just a year. And after their braces are removed, they may resume a 6-month recall. Some patients in braces maintain good oral hygiene and they may only require to be seen every 6 months. Remember that outside of this treatment plan, you want to control all systemic and local contributing factors. Therefore, if there are overhangs or other restorations that have loss of marginal integrity or things like that, you want to make sure you control all of that as part of your treatment plan. When we look at treatment plans, especially for those with slight to moderate chronic periodontitis, we're going to talk about the flow of treatment. You again always begin with the 1330, which is patient education and oral hygiene instruction. Second, you would have the code 4341. That's if you had 4 or more teeth in a quadrant that required scaling and root planing. Or you could have a 4342 where you have 1 to 3 teeth in a quadrant. So with the 4341, that would be generalized perio in that quadrant, and with the 4342, that would be localized periodontitis in that quadrant. Next, for number 3, the 4912, which is the periodontal maintenance with localized scaling and root planing, it is an internal code. However, it lets others know that you have debrided the rest of the mouth that does not have periodontitis. So that could be accompanied with either a 4341 if you didn't have all the quadrants didn't have a 4341 assigned, or definitely for 4342 because we know that that code is assigned to teeth, whereas the 4341 is assigned to quadrants. Next, you'd have a fluoride. Remember, you have that if you have a high risk or if you're using it for preventative purposes. For number 5, we'd have a reevaluation, and the code is now a 4343, and you do that again 4 to 8 weeks after scaling and root planing. Then you determine if the patient should be on a maintenance. So the 4910 code would be if you had resolution of the periodontitis, or if a patient was placed on maintenance because you were working on their oral hygiene to get them to a point where either they would come to health, or if they did not achieve health, they needed surgery, they could now be referred to the periodontist. Remember, you're going to refer to the periodontist if you have residual deep probing depths, or if surgery was indicated, if you have mucogingival defects, furcation involvement, any of those type of things that would not be resolved with non-surgical therapy. Treatment plans that have a diagnosis of severe chronic periodontitis are usually referred directly to the periodontist. The findings usually consist of furcations, mobile teeth, vertical defects, mucogingival problems, deep probing depths, and severe attachment and bone loss. Anytime you find these factors, more than likely they cannot be resolved with simple non-surgical therapy. Therefore, comprehensive periodontal therapy that includes both non-surgical and surgical treatment has to occur in order to get the patient back to health. This is why we would normally refer this patient directly to the periodontist. The periodontist would normally follow the same steps as those for slight to moderate periodontitis with the incorporation of surgical therapy. One must first make sure that the oral hygiene is adequate, and then they can move the patient from non-surgical therapy to surgical therapy. Remember also that adjunctives can also be added to the treatment plan. For instance, we can incorporate medications, rinses, or things of that nature. So in a brief recap, as far as goals and outcomes, remember, mechanical removal of the biofilm is necessary to treat and prevent disease. Also, maintenance and the frequency, being at 3 to 4 months, is encouraged to also prevent disease. And finally, after periodontal debridement, reassessment and reevaluation should be done to ensure progress toward periodontal health. If it is not achieved at this state or at this point, then other steps have to be incorporated into your treatment regimen. Those other steps may include referral to a periodontist, or it just may include further oral hygiene instruction, and sometimes patients have delayed healing based on their systemic health. Whatever the reason is, all of these steps should be included, and a reevaluation is necessary. Now that we have looked at we have done the examination, we have gone all the way to the treatment plan, we have completed the treatment plan. Now we're actually going to look at the purpose of the reevaluation. The purpose of the reevaluation is to determine the effectiveness of your non-surgical therapy. You're going to assess the home care, and you're going to determine now if further therapy is required. So when are we going to do the reevaluation? First and foremost, we can do the evaluation from 4 to 8 weeks after completion of the non-surgical therapy. This time frame is associated with the healing. It takes 2 weeks for healing of the epithelium, and it takes about 4 weeks for the initial healing of the connective tissue before you want to probe. Therefore, you know already in advance that I'm not going to probe before 4 weeks because I'd want to get a true representation of where the patient is. As far as steps of the reevaluation appointment, they will not differ from your initial evaluation. You're still going to do your patient assessment. Sometimes we find out a medical status update at the time of the reevaluation, in which case now we have to send a medical consult. We still do our comprehensive perio assessment. We compare our initial findings with the reevaluation findings. Now, this is a key difference that is important because now you have a baseline and you have a follow-up after treatment. And then you can actually decide the next steps based on where the patient is progressing and or not progressing. With the evaluation and the factors that you're going to look at the reevaluation, remember I said they're basically the same things as what you looked at initially, with the exception that you now have a baseline and a comparative value. Okay, so let's analyze the data that we have at the reevaluation. Does the patient have any systemic diseases that contribute to the destruction of the periodontium? I'm looking at this because I've done my non-surgical scaling and root planing, but something just doesn't seem right. The patient seems like they're healing in a delayed fashion. So now I'm going back to my systemic diseases. Oh, they have diabetes and they are fairly controlled. That may have an impact. So those are the things that I have to think about because they may need more time for healing. Can the patient adequately debride based on their mental and physical state? Well, I know if they can't adequately debride, and I know that the primary etiologic factor is microbial plaque, then I know I'm already going to have some limitations. And those limitations may be for life. So I might have to accept something less than what we would consider ideal outcomes. And finally, are there any additional limiting factors that might be that need to be controlled? Because remember, before you do a reevaluation, you really should take care of all of those limiting factors. And if you don't, they're still going to have an impact. In further analyzing the data, I'm looking at my probing depths, and I'm also looking at my attachment levels and attachment loss. So with the non-surgical therapy, I expected a reduction of my probing depth due to recession, and that should occur about 1 week. Again, I'm not looking at the patient at that point. And then clinical attachment gain within about 3 weeks. So then I'm looking at the patient at the 4 week mark, and I should notice that I don't have any further progression of the clinical attachment loss, and that's the best way to support the data of damage to the periodontium. However, upcoming in January, we will no longer focus on the clinical attachment level unless you can clearly see the CEJ. And the reason behind that is because it's going to be your best educated guess. And this is one of the more difficult things that we do. However, you will still be responsible for knowing how to calculate the clinical attachment level because, again, it still is the best supporting data of damage to the periodontium. So this periodontal flow chart was actually something that was created in order for to try to make it easier for you guys to understand everything as far as the initial therapy. So again, we have the initial therapy, which is the scaling and root planing. You can re-eval for up from 4 to 8 weeks post scaling and root planing. Another key thing that I want to indicate to you, and hopefully you'll remember, is that if you scale and root plane 2 quads in January and the patient disappears and you scale and root plane those other 2 quads in February, you're going to debride that entire dentition at your last appointment so that when you bring that reevaluation forward, you're on the proper timeline for those 4 to 8 weeks. So let's go back to the chart. So reevaluation. What's the next step? Well, if the patient is doing well, you're going to put them on a maintenance. If the patient has scaling and root planing and it was adequate, I'm going to the right side now, but they have BOP and some remaining deep probing depths, you're going to refer them to the periodontist, or if you're at school, to grad perio. Now in the middle, let's say you completed scaling and root planing as needed at the reevaluation because you noticed that once they had the recession and the clinical attachment gain, that you actually noticed there were some areas where calculus was missed. So you're going to go ahead and do that at the reevaluation, but then you can still have them in for a maintenance, and you don't have to do a formal reevaluation once you do the next maintenance, but you're just following up to see if they're doing well. If they're doing well and they don't require any further therapy, you would just keep them on a maintenance. Let's say they're not doing well, but they're not willing to go into surgery. That's where you drop down to the red box, which is a compromised maintenance if you have limitations such as health, money, or if they opt out of surgery or grad perio. Remember, also, if they have poor plaque control, they still cannot go over to grad perio. We have to control the plaque control before we ever send them to grad perio. If we don't, when you have surgery, you're actually creating more areas for them to clean. If they are doing an inadequate job with less areas to clean, just imagine you're actually compromising their abilities if you put them in a position of surgery and they're not ready. This chart was included just to give you, again, a further breakdown that actually includes the surgical phase as well as the restorative phase. So as far as you having a periodontal pocket and you diagnose as periodontitis, you start with your phase 1 OHI and scaling and root planing. If you follow the chart to the left, you're going to do a reval, and if the patient has good compliance and they have improved probing depths of less than or equal to 5 millimeters with no bleeding, then you can take that patient into the secondary restorative phase, because remember, you did your primary restorative phase or treatment phase 1 simultaneously, and then that patient would be put on a maintenance every 3 to 4 months. If you go to the right, where you have a reval and the patient is not compliant, you're going to follow up with a maintenance. And even though we do not maintain disease, you have to get that patient to a point where they have improved plaque control as well as they're compliant and ready to go to the next phase so that they can have their periodontal surgery and then come back and have their secondary restorative phase. If they never become compliant, they never make it to this phase, because we would actually be doing a disservice for the patient. And then finally, if you go back to the re-eval on the right where you have good patient compliance and you follow the diagram to the right and you have persistent deep pockets with BOP, that patient is now ready for periodontal surgery. After we finish the periodontal surgery, you can do the restorative phase, where that phase 2 of the restorative, your crowns, bridges, things like that, even implants, so you can get ready for implant supported crowns. And then they would also be put on a maintenance of every 3 to 4 months. Although I'm not going to go into the periodontal surgeries, I just want you to know that these are the different type of surgeries that can be done, and they're listed on this slide as well as the next slide. These are just some additional surgeries. However, you will be introduced to each one of these in the winter semester of your DS2 year. First and foremost, we want to thank you for listening. And then I am number 592, and then Dr. Campos is number 29. You will see us for Periotherapy 2 in the winter semester of your DS2 year. Thank you.